Hi, my name is Walid Tawfiq. I'm orthopedic specialty doctor in Newville District Hospital. We will discuss this scenario today. As you can see in the pictures, uh, this is 72 years old, a man who had presented to ED by 2 weeks history of progressive left knee pain. He attended today with unable to bear weight. What do you see in the picture and how you are going to manage this case? So this is a clinical photograph of the gentleman knee showing a swelling of the left knee. There is a midline scar consistent with midline approach. There is another scar on the medial side of the knee. The overall is possibly suggestive of high BMI. There is a pleural discoloration from the mid leg down suggestive of chronic venous insufficiency. The plane radiograph EP and the attempted lateral of the left knee showing a TKR CR in situ. I cannot see a radiolucent line through the femoral or tibial component. The overall alignment is satisfactory. I cannot see any peri-prosthetic fractures. So I will approach this case by putting differential diagnosis for a painful total knee replacement. First concern is to exclude infection. Other causes I had to exclude malalignment, patellofemoral joint uh, problems, instability. Soft tissue include quadriceps or extensor mechanism disruption, osteofibrosis, nerve injury, and CRPS. I have to exclude referred pain either from the spine and hips. I will take detailed history of the present complaint. I will ensure the pain is coming from the knee joint itself. Ask about history of red flags suggestive of infection. I will do an Oxford knee score. What treatment so far and what outcome? What is the patient limitations and expectation? Past knee history includes the index procedure, indication duration, perioperative period, and outcome. Other joint history, especially replacement for ipsilateral hips. I will ask about past medical history, how fit is the patient for any further surgical intervention, if he is immunosuppressed or not, and history of smoking. I will proceed for examination looking for general, PMI, and observation of the patient if he is septic or not. Local, I will look for the skin, scar, any sinuses or redness. I will feel for hotness and tenderness, check his range of movement, and I will check his extensor mechanism. Finish my examination by examining the spine, hips, and neovascular status. I will do investigation based on the British Orthopedic Association Guidelines 2020 in the form of imaging, by including the previous radiograph, and the lab, including full blood count, using CRP, and the blood cultures. And if I suspect infection, I will arrange for aspiration under complete aseptic technique in theater. I will send the aspirate for microscopic examination, gram stain, culture sensitivity, including in blood culture bottles, and cytological examination for white blood cell count and differential. While my treatment will be based on my diagnosis, the aim of treatment is to patient stabilization, find the source of infection and eradicate it, obtaining a well-aligned gap-balanced implant with restoration of the joint line. The guide is POA guidelines for infected TKR, and such cases, the principles is a complex cases need a multidisciplinary approach. Option of treatment mainly operative. The role of non-operative treatment with long-term suppression antibiotic is very limited to specific cases. My intervention based on the disease factor, implant factor, and patient factor. The disease as regards the onset, is it more or less than 4 weeks, and the organisms that had been isolated. The patient factor include he's septic at the moment or not, any comorbidities, and what his soft tissue condition looks like. The implant factor, is it a well-functioning, stable knee, and what's the brand of it if I have any modular component to be changed. And the outcome of this intervention either there or one stage revision or two stage revision. I have to do a pre-operative planning with multidisciplinary team, including the anesthetic team, to optimize the patient pre-operative. Senior knee revision surgeon. If not available in my trust, I will refer to another regional center and other specialties. Definitely microbiology come on the top, followed by physicians according to the patient comorbidities. I will involve the plastic team if I have a soft tissue issue. Intraoperative, I will do my exposure. That's classical for any kind of intervention by doing longer incision, extended my medial patellar approach, doing synovectomy. I will do a radical debridement and copious lavage. I will obtain biopsies. The principle of that, 5 at least, with clean instrument for each sampling, urgent microbiological processing, and I will include culture sensitivity and the histological examination. The procedure will depend on what I'm doing or achieving. If it's a day procedure, only modular component to be removed and replaced. All the prosthetic surface should be accessed and washed. For one stage revision, that's a bit limited to special centers and surgeon and the specific circumstances, like I identify the organism, good safe tissue, and the patient can tolerate that pretty well. And that involve debridement, removal of the component in a bone preserving manner, reconstruction using antibiotic cement based on the microbiology advice. If it's two-stage revision, removal of the component is exactly the same, but instead of a permanent implant, I will do a spacer that can be either dynamic spacer or static, or sorry, articulated spacer or static based on the soft tissue condition. That is was traditionally the gold standard with the best outcome. The second stage revision will be most cases the implant arthroplasty. As regards the soft tissue construction, if we have big sinuses, soft tissue defect, I will involve the plastic team doing a medial or lateral gastrocnemius flap according to the site of the defect. Post-operatively, this patient needs a routine rehabilitation, wound protection, patient optimization, antibiotic according to the microbiology advice, and follow up the patient clinically and the laboratory, looking for the trend of his inflammatory marker.